what are the elements of orthodontics and consent in orthodontics which may be different to general consent?
Yes, I think the key thing is with orthodontics, there's a few things. One is compliance is a heavy factor. So if you're doing aligners or even fixed appliances with elastics and retainers afterwards, the patient is on board. Do you accept the overjet or do you not do the treatment or surgery? If you do it, the classic adage is if you say it at the start, it's consent. If you say it halfway through or even fixed appliances with you're making excuses for yourself, it's picking that up from the start. Which cases do you know you're going to end up with an overjet?
When I had ortho, no one warned me that my lower incisors could lose vitality, right? And they did. So I'm just saying, it's rare, but I'm sure it's not the first time you heard of this. So
I'm annotating it like you said. We get them to sign each line. So
wow.
It might be, or initialize each line. The reason being is we've seen it where someone signed at the back of a page and not the front of a page or something like that, or page 2 or page 3. And they say, well, I never saw page 1 and 2. I just signed this page. So,
wow.
The smallest little thing can make or break your day.
Isn't orthodontics just wonderful? I find that ortho, whether I do it or I refer for it, helps my patients so much in my tooth wear cases. I think 70 to 80% of my tooth wear cases would benefit from some pre-restorative orthodontics. And it's been great over the last 2 decades to see the boom of adult orthodontics and also GDP orthodontics. But because more adults are having ortho and more GDPs are providing it, we really need to talk about consent. How good is your consent for ortho? You see, I used to think that in restorative and in inclusion, there's so many different camps and dogmas and different opinions. And then I was exposed to the world of orthodontics. And oh my goodness, it's a whole new level of different beliefs and opinions and different camps in the world of orthodontics. Whilst we're not going to go into all of that, we are going to go very deep into that consent conversation you need to have with your patients. What is an appropriate level of consent? What are some common things that GDPs may be missing? I'm joined today by Dr. Zaid Esmail. He's a UK-based specialist orthodontist, and I also have our good friend Dr. Neil Jaiswal making a return on the podcast to give the medical legal perspectives we need. Look, there's a lot that can go wrong in ortho. The biggest point being managing aesthetic expectations of your patients. There are different risks for different movements. Some movements are less predictable. Aligners versus fixed appliances, that has its own conversation. Loss of vitality. Guys, I lost vitality in all 4 of my lower incisors from ortho. I don't think I was warned. I don't remember it. And I was like 13 or 14 at the time. It's a very rare risk, but it happened to me. And I've seen it a few other times in my career. So there's lots of rare things, but lots of common things that we need to discuss universally with our patients. But the crux of this episode really is individualized consent. And this episode really guides you on how to do that with your own patients. Ultimately, so your patients are better informed, you have a better night's sleep, and avoid any litigation. Now, every PDP episode, we give you a protrusive dental pearl. Today's pearl is a reminder that whether you're doing a wisdom tooth extraction or an orthodontic case, it may be your 100th, 500th, 1000th case that you've done. But for your patient, this is a significant event. Never forget that. Even a routine extraction, it's routine for you, but for the patient, it's a big deal. And I think the more we remember this, the better empathizers we'll become with our patients. And I think our communication would benefit. And intertwining this with the topic of this podcast, talking about risk and consent and things that can go wrong, one way I really like to communicate my patients when it comes to specific risks is by making my patients feel special. Now you're thinking, what does that mean? What do you mean make them feel special? You sing them a song or something? Well, if it's their birthday, I might. But jokes aside, what I mean by that, and I'll give you an example. If I'm removing an upper first molar, now we know that the routine risk is an oral-antral communication. And for some people, it's more of a risk than others due to the radiograph. But when I see someone who's got slightly more risk, in a medium risk or high risk, I will make them feel special. I'll point out on the OPG where their sinus is, and I'll say, hey, your sinus is actually very interesting. Hey, your roots, did you know your roots are really long? You see, that kind of language. Your sinus is interesting, your roots are interesting, and patients remember this. I've observed in my career that patients really do remember and recall this kind of information where they've been made to feel like they're a special case or a little bit different, a little bit not unusual, but unique. That's a good word. Make your patient feel unique. This makes whatever you're telling them as part of consent really memorable to the patient. So remember guys, it might be routine for you, but it's special for your patient. And if you want to help your patient really recall that risk, make them feel unique. Let's now join the main episode. I'll catch you in the outro.
Welcome back again, Dr. Neil Jaiswal, our resident medical legal dude and dentist, of course, and Zaid Esmail, orthodontist.
Yep.
and it's great to talk about consent in orthodontics. But before we dive in, Neil will come back to you second because you know a lot about you. You're a veteran. Zaid, tell us about yourself and your background in orthodontics. What got you into moving teeth around?
So I've been a specialist now for 10 years. So I always enjoyed that part of it. I remember doing work experience at Dentsu, did a bit of orthodontics and actually quite enjoyed that. And then went into undergrad, and it was very poorly taught where I was, and it kind of put me off it again. So then when I qualified, did VT, he did a bit of orthodontics, kind of got into it again, quite enjoyed it, and then just went down that route. And I knew I kind of wanted to specialize. I needed that kind of almost that focus of the next stage is doing the next stage is that. And actually just, I don't like specializing. I like the idea of working in practice. I like being busy in practice. I was never a huge fan of the hospital system. So to be able to kind of, and actually orthodontics lends to that very, very well. So yeah, I've been a specialist 10 years now, based in the Southeast.
If you'd asked me when I was 18 applying dental school, where you want to be, I don't want to be a dentist. I wanted to be an orthodontist, right? And I wish I'd done that because I'd be driving a nicer car if I was. So talking of nice cars, Neil, remind us about yourself, Neil, for those who haven't listened to the podcast before. What do you do and who are you? Who do you represent?
Sure. My name's Neil Jasel. I've been in practice for about 30 years. Private practice. Before that was NHS. Before that was Max Fax. Before that was Australia. So been around a little bit, and started an indemnity company introducing dentists to brokers and insurers, which is going really well. And I know Jazz, you're a part of it. As Zaid, you're a part of it. So thank you for your support. And really what we want to do is, you hear distress and difficult times on, D4D, etc. on Facebook every day, and we just want to reach out to those people and help them and put an arm around them. And also our existing members, who want to foster really good ethical dentists doing the right thing, protecting themselves and having a wonderful career.
Well, Neil, thanks so much for connecting me with guests like Zaid, who really help out with the medical legal side. Some of those episodes have been brilliant discussions about when aesthetics go wrong, or consent, about different areas of dentistry. And today, orthodontics is a huge one. Because Zaid, I'll tell you something, mate. When I had ortho, no one warned me that my lower incisors could lose vitality, right? And they did, right? So I'm just saying, it's rare, but I'm sure it's not the first time you heard of this, right? But So do you see what I mean? It happens, right? No one warned me. Right, no one warned me, but it's one of those things. Maybe it's written somewhere, I don't know. So I really want to get into this. Obviously, I have no hard feelings. As a dentist, I understand that things happen. It wasn't the orthodontist's fault, I hope. It's one of those things. But we need to stay safe. So really, the purpose of this episode is, how can we make sure the GDPs out there are consenting appropriately, with the sole aim not only to make sure the patients understand more and get more from it, and the right type of patient goes ahead with treatment, but more importantly, staying out of trouble. So the first question is, what are the elements of orthodontics and consent in orthodontics which may be different to general consent?
Yes, I think the key thing is with orthodontics, there's a few things. One is compliance is a heavy factor. So if you're doing aligners or even fixed appliances with elastics and retainers afterwards, the patient is on board. If the patient's doing a filling, if you're doing a filling on a patient, there's no compliance involved, because they sit there and you get on with it. But with orthodontics, it's compliance with the cleaning, compliance with coming to the appointments. That's a big factor. And also, we do know risks that are associated with orthodontics. It's quite uninvasive orthodontics compared to other parts of dentistry, but there are risks associated with that. So sometimes when we think, the common mistake to make is that, actually it's just braces or just moving teeth, what can happen? So it's knowing what the actual risks are of the treatment. And there are, some well-documented risks. Thankfully, some of them are preventable, and thankfully the ones that are more severe are much rarer. But it's important discussing that with the patient. And it comes down to anything like everything else, is a risk benefit. So you said about your lower incisors. I suppose the question for me to you is, if you'd have known you've lost vitality on your lower incisors, would you have still gone for ahead of the treatment or not? That's if the answer would have been no, I wouldn't have had it.
Yeah. My problem was a huge one. For me, I would have definitely had it, right? But it's one of those things that, example of all consent in orthodontics, and my own personal scenario, I was like, no one ever warned me about that.
Yeah. And that's a difficult thing, because we hear, sometimes we see it all the time. We have that conversation with patients, we explain it to them, they come back in the next visit and they go, what was that again? What do I do about the retainers? Or what do I do about this? And thinking patients don't retain all that information in. I think that's a key factor of that. So I suppose the other thing with orthodontics is, obviously we're seeing our patients quite regularly. So there's a chance to kind of reinforce that consent and make, when I talk about retainers with patients, I talk to them right at the start of the
Look, Neil, Zaid's already mentioned that there's these unique aspects of consent, which we're going to get into. I'll ask Zaid, okay, what are the things that we should be consenting every single patient? And then how do we know in which patients to talk about that lower or teeth losing vitality, or should it be for every patient kind of thing? and I'll get into the nuances of that. But Neil, I want to understand from your medical legal perspective, what percentage of the pie in terms of litigation does orthodontics represent, and what percentage of that is related perhaps to consent?
Well, I think it's a very good thing to start with, so that your listeners will pick up a little bit that actually removable appliances is a really big risk factor in complaints. So I think anything removable. Fixed is very low. So I would say if everyone wants to do fixed, it's like 3% or something. It's really low. But removable is like 15, 16% of complaints to the dental complaint service. And I think there was like maybe
Why do you think that is?
There's an aesthetic need, it's adult patients, it's less, maybe the function. I always stress
compliance,
the function.
as Zaid said, compliance.
Well, to me, my patients are functional patients. And by the way, it'll look better at the end, but you've got where the teeth are in the wrong place. I always go for function, and my patients value function and health. But if your practice is perhaps a younger driven audience, it's cosmetic, which then is really subject to variability. But no, it's more than crowns, it's more than implants. So if you are doing aligners, and the nice thing, if you're doing a lot of them, it's quite easy to get it pat down in terms of your consent. It should be the same thing, same time. These are the risks. And the other difficulty, I think, which I'm sure Zaid will mention on, is you might have signed that consent form 2 years ago. And I was just thinking yesterday, is there something that we should be sending to the patient every year or every 9 months, just to say, by the way, we started a long while ago, here's your consent form that you signed, and just wanted to make sure that nothing was, anything had changed from your point of view, or did you have any further questions as we're progressing? Just to keep that consent valid over time, which is very difficult. And I think the other thing is, with valid consent, has to be pertinent to the patient. So I think you really, a little bit of the social history initially. Why do you want it done? What are you expecting? Can we meet your needs? Are you a professional singer? Are you on TV? All those little things that we now have to kind of consider the material risk to the patient, not just a general patient.
Well, you mentioned valid consent, right? And so, Zaid, for your patients who come and see you, what makes your consent valid? How can we make sure that, so for example, there are some general things which we may warn any orthodontic patient: the risk of resorption, the risk of some rotations being difficult and incomplete, the risk of temporary joint changes and bite unsettlement as they go throughout treatment, all that kind of stuff, pain after the first few days of wearing fixed appliances, for example, all these general things. How do you make sure that it becomes valid for that individual and becomes unique to that individual?
Yeah, so I think that comes down from an assessment and diagnosis aspect. So, for example, one of the risks is root resorption, but we know that patients with shorter roots or blunt roots or long spindly roots are more likely to have root resorption. So when every patient that we take the OPG on before we start treatments, we would look at those risk factors. And also we know actually you've got really long roots. So chances are, even if you get a little bit of root resorption, it's not going to be an issue for you. Or this tooth in particular has got quite long spindly roots. The worry that the risk of root resorption is going to be higher on that tooth. So then we're kind of individualizing our consent for that patient. And when it comes down to things like aligners, well, we know certain movements aren't as predictable with aligners. It's picking that up from the start. That lower canine's quite rotated. Don't know if we can fully line that up if it's not quite there. And I think this is one of the things that, as a specialist, I can put a fixed brace on to get that bit right. So, and I wonder whether what Neil was saying earlier about removable appliances, the ClinCheck can look very, very good. And if, as a dentist, if you don't know that, you could be kind of lulled into that false sense of security, because actually a ClinCheck is a force movement table, essentially, as opposed to an outcome simulator. And I've seen plenty of ClinChecks where it looks like you've got the perfect result, but any computer simulation can show that, and actually being able to know what you can translate to the patient and say, this is where we can get to. And I use the ClinCheck as a consent tool. If I've got patients who've got different options, I would run 2 different ClinChecks, but I'm not setting up the same. The ClinCheck that I set up for my aligners is actually different to the one I show the patients, because the ClinCheck is the aligners, the force on the teeth to able to get that end result. The end result is what I show the patient, or what I think I can get to. So it's having that knowledge and being able to impart that onto the patients and using that as a consent tool, I think is really useful. Similarly, that we know, devitalisation is a risk of orthodontics, but we know it's a higher risk if they've had previous trauma in the past. So if the patient has had a trauma history, then we know we can say to them, actually, normally devitalisation.
Is that on your form, Zaid? Devitalisation. Obviously, I'm personally interested in this one, but is that on your consent form? And just tell us about where does it actually fit into your appointment? So you have your consultation. You send them their letter, or whatever, just tell us your flow. And then at what point does consent happen? They come back and you present to them and you go through the form, or how does consent work in your practice as a system?
Yeah, sure. So basically when they come in, we get records, we give them an idea of what the plan is going to be, and we talk about those risks, more the kind of the individualized risks of the patient. So, if they've got periodontal disease, maybe we talk about black triangles or active periodontal disease, we have to get that sorted. Once they're kind of dentally fit and ready to go, we bring them back in and we talk through the plan of the treatment and the consent. So doing it over 2 appointments where you're almost repeating yourself the second time round, it gives them a chance to have a think about what's happened in between. And then we go the full consent process. It's all written down, and we also go through it verbally as well. And we know the risks. You've got it's the same risk discussed for a lot of patients for orthodontic treatment. So root resorption, we know higher risks if they've got spindly roots. Decalcifications or poor hygiene. But again, if they've got poor hygiene, we probably wouldn't get that far in the process. But we'd still have to warn them on that. And again, that's a preventable risk if the oral hygiene and the sugar intake is under control. Devitalisation, again, we also mentioned that if you're higher risk if you had trauma in the past, you're higher risk of having devitalisation. Relapse is a big thing. So we talk about retainers from the beginning, and we talk about the different retainers that are available, the fixed and removable retainers. Advising really, it's a lifelong aspect. It's not, relapse happens in different ways. You've got, periodontal ligament bounce back, but we know teeth will naturally move throughout life. They'll become more crooked as we get older. And everyone's very different in that sense. So whether you've done treatment and 2-3 years down the line, they're wearing the retainers and then suddenly they stop and the tooth moves. That may not be exact orthodontic relapse. That could be physiological tooth movement. But from a patient point of view, relapse is relapse. The tooth has moved. So again, it's advising that they're in it for the long haul with the retainers. And things like recession. So if the patient's already got some recession and we're going to do it on a non-extraction basis, we've got to then advise actually the recession risk is increasing and getting worse. So again, it's tailoring it to the patient. And obviously on treatment failure, if we don't get the result that we want for whatever reason, or if the compliance wanes halfway through, we've got to know when to say now it's time to stop. If a patient has decalcification through treatment, do we just carry on or do we stop at that point, or where do we change the end point? With things like root resorption, if there are higher risk, the guidelines is we take an OPG 9 to 12 months into treatment. So at that point, we think, okay, we've seen a bit more root resorption in that OPG that it's a year into treatment. Again, it's having that next conversation of, do we carry on and risk further root resorption, or do we change our end goals so that we can reduce the amount of root resorption that happens going forward? So it's really tailoring it to the patient and having it all written down as well. And make sure they're fully happy before we begin. Like I said, I think from my point of view, I think orthodontics is quite low risk compared to anything else. It's less invasive. I think a big factor of that as well, we get to know the patients. We see the patients every 6 to 8 weeks. So we become almost friends with them during that time. We're seeing them quite regularly. So when you build up that relationship and that rapport with the patient, you're less likely to get a complaint at the end of it if you've done things properly and if you've kind of treated them as a family member or as a friend. And obviously we explained the stuff about that first week, rubbing on the cheeks and stuff like that as well. So it's kind of, it's a full appointment of just discussing it. But at the first appointment, I'd also discuss it as well, because you don't want to go that far if the patient goes, oh, absolutely no way, I'm not having it for that reason. Like I said, the big risks of the root resorption and devitalisation, thankfully they're very low risks, but they are higher in certain percentage of patients.
Is this essentially all on your consent form, and you're just sat in front of the patient and you're just going through each point, and then you are making it bespoke to that patient and saying, well, in your case, that's less of a concern. This one's more of a concern for you. This one's less risk, but you're essentially covering all of it. Have I got that right? That's what a typical appointment looks like for you, and how many minutes are dedicated to this consent discussion with the form in front of you both?
And it's usually about 20 minutes to half an hour. So at least 20 minutes. And if it goes over, it goes over, because, I think it's important the patient's fully aware of that before they proceed into treatment. And also I got my treatment coordinator who's also goes through it as well. So they got any follow-up questions, the correspondence usually comes from her, so they can always say, oh, can I just ask about this? And we always advise them, if there's any issues, you let us know before we start. Like I said, I think it's a very important process, but it's just having everything at the start. And patients will still forget it. Near the end of my appointments, I'll talk about retainers, and they'll be like, what are retainers? I said, we've discussed it all. So 2-3 pointers before we're getting to the point of finishing the treatment, I'll reiterate again about what we do about the retainers and the long term. So it kind of, I think it has to be several points that have to be repeated for them to retain the information.
One's got a very good tip about consent. being that when, like, it was specifically for wisdom teeth, but it can be applied to anything, and I certainly do it. When I do a consent form, I will squiggle on it, I will draw, I will highlight, I will star, I will cross things out which are not applicable. I like the idea of that, making that a proof that you made that consent more valid, and they feel like it's okay. Actually, it makes you not skip something, and it also allows you to make it more bespoke. Is that something you do as well, Zai? Do you annotate? Do you draw? How do you get your patient engaged in that process?
Yeah, so I suppose I've got the consent form in front of me, but I'm not reading it out word for word. It's a conversation with the patient. The consent form is just a guide for me to kind of make sure I don't forget anything. But for example, I've got a big screen in my surgery. I'll put the OPG up. So if they've got short roots, I'll put the OPG up. I'll point to the roots that I'm concerned about. I'll point to, this tooth has had a root filling in it. We want to know the risks of that, or if it had trauma on this tooth. So, and even the photos of the patient as well. So get the photos up if there's anything related to that. If there's any treatments, and go, actually, I don't know if we can get this tooth moved here for whatever reason, or there might be more recession on here. So it's more kind of a visual effect as well as the speaking, as well as the written. And that's a good
Neil,
tip,
I used
actually.
to work in a clinic where we used to, I used to work in a clinic whereby the way it would work is, let's say the patient's booked in for a root canal with me, which I don't do much of anymore, thank the universe. But the patient would be having with a clipboard, and there'd be this 3 or 4 page consent form all about root canal. They'd be reading it by themselves on the clipboard, and then sign it at the end. And then they come in, and I might just gloss over it a little bit kind of thing, but that was their consent. And I decided, okay, then as I grow my career, I was early on in my career, I was like, okay, I don't think that's how consent is best done. I mean, I might be wrong, but what do you feel about if some clinics which may be doing it what Zaya does, but instead of going through it with them, they're like, here's your consent form, please sign. And then they're sat in the waiting room on the clingy pad or wherever, they're reading it, signing it. Is one consent more valid than the other? Or in the court of law, are they equal? Give us an idea about how important is it to, because it takes longer time and is more involved to do it Zaid's way, to with the patient, go through it with them, rather than go to the waiting room and you can see the next patient while they're reading and signing.
I think it's a good question, Jazz. I think actually one follows the other.
Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads, and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription.
And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you make an account on Android, iOS. If you make it on the website, you get access to the free trial and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description. And thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
What I would do is, I don't, like with oral surgery, talking about eights, we have a list of all things that can go wrong, paresthesia, OAF, whatever. And I might cross out OAF if it's the lower, and I might cross out paresthesia if it's an upper. So I'm annotating it like you said, but we get them to sign each line. So it might be, or initialize each line. The reason being is we've seen it where someone signed the back of a page and not the front of a page, or something like that, or page 2 or page 3. And they say, well, I never saw page 1 and 2. I just signed this page. So, the smallest little thing can make or break your day. So I actually like either you do it at the bottom of each page so that they've seen the page, or for us, it's a 1-page thing with oral surgery and it's tick, tick, tick. So for me, I would prefer something like retention has to be lifelong, compliance has to be there. You might need edge bonding afterwards. There might be residual spaces. There's a risk of relapse, and they sign it all. And you might, like you do, annotate a little bit. But that's really followed up with notes that said, we went through the consent form, a discussion was had, there was no more information requested, the patient asked these questions, and I'd write down what they asked because it's really personal. Or, will I still be able to have my coffees? Or, can I take it out when I'm on a call? Really makes it unique to that particular patient because you've really had a chat and not just a signed form. Can be pretty useless, but it's a really helpful adjunct in a way. Then it leads you to the next conversation. I also write, why do I prefer this option? What are the risks of you not doing this? What's the chance of success? Is it low? Is it moderate? Is it high? Are the costs been given? Risk versus benefits. So this is following on from, I'd get everything signed and then I'd have the conversation about the consent form and add your personalization in that record. Or your nurse can write it while you're talking, as Zaid would do. But I think you need both. One on its own, they might say you didn't get a consent form signed. Without the other bit, well, the patient didn't understand the consent form. So I think I'd probably say it, but it's better to be safe and have both.
Okay, I like that. But let me, and I'm making myself vulnerable here for both of you, because this is how I do my Invisalign consent. And you guys tell me if I'm not doing it well. And more honestly, I'm that type of guy. I will change it, right? And you guys tell me. And also, don't say it's good just because you're on this podcast and I might not publish it. I'm just kidding. I'm not publish it anyway. You know that, right? So here's the thing. I go through the consent with the patient in the chair, like more pertinent points, like have you had a trauma history and whatnot, and we'll go through the main points, which I think are applicable to them. And as you may, or Neil knows for sure, I use voice recording for all my consultations. There's voice recording there. So as Raj Ratan said, consent is like an onion. There's main layers to it. So I've got the one layer of me having that verbal conversation. The second layer is being recorded, and the patient's and yes and is being recorded. Okay. And then I send them a YouTube video, me going through the 15 points that I've come up with that, okay, this could happen to you when you're wearing aligners. Okay. I email them that video, and I will then say, for you, Mrs. Smith, points 2, this bespoke thing, that actually you're low risk of this, and points 9 are very pertinent for you because of this, what we discussed. Please reply back when you've seen this video, and then I wait for that email. That's my third layer. Okay, the email say, oh yes, I see it. That was a very good video. Thank you, kind of thing. Critique.
Excellent.
Okay.
You're doing what we said, but you're doing it in a better way because it's not just written notes. You've got the audio notes, and you've got a visual thing, and you've also checked that they've received it. Because you might send them something saying, I didn't get it. So you are actually waiting for them to say, yes, I received the video, thank you. So I think that's excellent. You've got consent, you've got a visual thing, you've got feedback on it, you've had the opportunity to think about it. I think pretty gold standard, yes.
Zaid, anything to add to that?
No, I think the only thing I'll probably say is, I'm sure you do it anyway, but I think it should be in that, if there's anything you don't understand from these points in these videos, let me know and I can then explain it further. I think it's that aspect. Sometimes they're just very under pressure to go, yeah, that was good or what have you. So I think it's
That's true.
It's that.
That's true. It's a
That's
good
probably
point.
the
I
only
think it's
thing.
in there in my sort of template, if you like. But
Yeah.
that's a good point to make sure we give them an opportunity to have some time, think about it, and ask any questions. It's a very good line to put in anything you do. Like, do you have? Even when I'm like doing the voice recording, obviously, it's like, have you got any questions about this? It's important to make them understand that they're welcome to ask any questions. That's a very good addition.
Yeah.
Jazz, do you have anything about, and Zaid as well, the fee for this is £4,000. If you don't wear your retainers and you need new retainers, there's a fee for extra printing. If there is relapse because of this, to redo the ortho, we will do it again at the 50% rate. Are you almost preempting them saying, oh, this has happened now, are you going to do it for free? Are you setting them up for, if there is failure, they know what it's going to cost them?
So
Zaid, you go first, mate.
I have a costings as well as my consent. I've got the treatment options that we've discussed, and then the cost for treatments in each one. And with my costs, I try and cover everything. And also, I put bonded retainers on my private patients, as well as Essex. I'm using dual retention for everyone. And we have included in that as a guarantee for 2 years. So any problems with the Essex or the bonded retainers, we replace. The Essex we normally replace within a year. If they're broken, the bonded retainers will sort out within 2 years. And that's all that covers. We don't really, say that everything's all covered. And then there is a line saying any further treatment will be an extra cost. But to be honest with you, if I ever have a patient that comes back and has had that relapse within 3, 4, 5 years, especially if it's in a Invisalign case, a lot of mine are comprehensive. You've got 5 years. I will just do it free of charge as a patient build, as a practice build, for the sake of a section or fixed or a few extra liners. I've only had to do it a couple of times where they've broken upon the retainer and then the tooth have moved and then they haven't been in. I think for the sake of less than half an hour's chair time to get that patient in. So then I say that there will be a cost, and a lot of times I would waive it.
I would
think
still
that's a great
say,
point, Neil.
Sorry, Joe.
I just want to say that I'm going to definitely change this. I'm going to add this on because I do it for my veneers. Like if I do veneers, which I'm not prolific in, when I do them, like, hey, you'll first be checked that you're happy with the shade before we glue them. Once they're bonded in, they're in place. Should you change your mind afterwards, that's completely fine. But it's per veneer, it's replacement of £800, blah, blah, that kind of stuff. It's all in there in those ifs and buts. But I don't do it for aligners, and I think that's a great point. I'll add that in. But you were saying, sorry.
So again, just the cost of if the bonding is chipped, how much is a new wire? Because I've replaced a few wires. I never know how much to charge. And so I think you should do it, Zaid. But what I would do in your case is say, as per our terms, we normally charge £2,000 for this, but you've been such a great patient. You've come regularly. You've really sent me Mrs. Jones from next door. I'm happy to do this for free. That's even a nicer thing for them because they've actually realized that you're doing it out of goodwill in your relationship.
I did bring that up. Yeah. It's usually the
There's no
reception that
value
have that
to it, but if they
conversation.
know.
Yeah.
So I think it's safer for everyone, for the patient as well, because when they break something, like when an implant fails, for example, they start coming in angry because they're expecting a big cost, or like, I've just spent £4,000, and then you have to calm them down. If you've already told them your implant is for 2 years, don't worry, and after that, the cost of this and this. So it sort of sets the tone before they come in, because people are worried about the cost or what it's going to take, or am I going to have an argument with someone, because they may not be used to dealing with nice people like Jazz and Zaid. They might be used to dealing with dodgy builders where you have to have an argument each time. So to sort of set the case, these are our fees, this is what the future may cost. We generally have a lot of goodwill, and that makes it clear for everybody, I think.
I want to then follow on from that and say, Zaid, in your education space, you teach dentists orthodontics, what are the things that are worrying the dentist when they're doing their first few aligner cases or fixed appliance cases? What are the things that worry them, or complications that they run into that makes them think that, oh, did we consent for this appropriately, or how do I manage this now? And having those hairy moments, if you like.
Yeah, so I think we'll kind of split it up into kind of fixed appliances and aligners. I think the big issue with aligners is the ClinCheck looks so simple. So it looks like you've got a great result. Just accept, they think it's an orthodontist at the other end who was setting up that ClinCheck. But obviously, like I said, you can make tooth move in any directions on that. So it's not knowing what's going to happen during that treatment. And then that's kind of one aspect. So the ClinCheck would sort of lie, if you like. You can be logged into false security with the ClinCheck. There's always that worry of, have I got the right attachment here and there? And I think with the liners as well, when the patient then comes back, it's a bit of an unknown. Did I plan it correctly with my tooth movements, or has the patient been bearing it? So it's kind of that aspect of it. So that's why when I tell patients that are dentists that are starting with aligners, do everything as a comprehensive. I think that if you're doing, you might get away as a light, and then you run out of aligners. What do you do then? If you're starting out, the worst case scenario is you just do another refinement and do another refinement and do another refinement. You're not out of pocket. You're not trying to trick the patient and go, well, I've got to pay for an extra refinement now, and the teeth look fine, don't worry about them. I think you just keep going, and you will learn from that. The big issue with the fixed appliances, this came about from the whole 6-month smile thing that was around quite a few years ago, where it was focused around anterior alignment. And I think anterior alignment in some patients is a perfectly reasonable treatment modality. I think the issue is it's that underlying class 2 case, underlying class 2 div 2 case, where they look like a bit of crowding, suddenly line them up and they've got a stalking overjet. Now, you haven't warned the patient about that overjet. The difference is I would do the same treatment. The difference is I'd have anticipated that and gone, actually, we line them up, you're going to have a big overjet. Do we take out upper fours? Do we accept the overjet? Or do you not do the treatment or surgery? If you do it, the classic adage is if you say it at the start, it's consent. If you say it halfway through, it's you're making excuses for yourself. Because picking that up from the start, which cases do you know you're going to end up with an overjet? And I think that the worst ones are where they're tooth of two, they've got contact on tooth. Suddenly you procline the teeth. Suddenly they lose contact. Those lower teeth are now biting on the palate. So now you've created a traumatic overbite for a patient, and you hadn't picked that up from the start. And then the only option then is either jaw surgery or extraction of fours or not of IPR to bring them back. But if you haven't got that knowledge to do that, or you didn't know from the start, what's the next conversation with the patient? It's going to be a referral to an orthodontist, who's then going to pay for that. And then you've lost that trust. And then that more worrying, that dentist then loses confidence in that. So it's again picking up from the start. So with a lot of my courses I do, I provide mentorship for them. So we pick up these cases from the start. We know what it is. The dentist then can appropriately consent the patient. It's just knowing where we're going to go and then managing that with the patient expectations. So, if you're going to end up with an overjet 7 millimeters. Now, the problem is a patient is not going to know what a 7 millimeter overjet is. So at least with the ClinCheck, I'll do 2 ClinChecks. I'll show them one route, what the teeth look like when they're forward, and then one, if we took out upper fours, what it would look like. But also in some of those patients, I'll say to them, okay, we'll start non-extraction. You're going to end up with a 7 millimeter overjet. If you don't like that, we can take out upper fours and bring them back. And then the teeth are straight, you can see them and go, actually, I don't mind it. I don't mind that. Or take up reports. Now, the problem is if you're a dentist who's just doing a few aligner cases or just doing a simple fixed cases, what do you do then? You can't have that. So then is it referral halfway through the treatment? Do you have an orthodontist you can refer to who's going to be able to take that on? But if you've picked that up from the start, or you've at least got the knowledge that you can treat extraction cases with proper mentorship, then that's kind of one way around it as well. But I think that's the biggest thing. And, you always have 1 or 2 cases where dentists will get their fingers burnt. And it's that classic, the Dunning-Kruger effect. At the start, you think, everything's all going really well. You have one case that burns you, your confidence goes down, and you don't know what you don't know. So, but when you see the ClinCheck and it's kind of belonging to a false security, I think that's the issue with orthodontics. And I think that's why I come back to what Neil's point earlier about more complaints in removal. And I wonder whether it is the case of that, because some dentists that I see will, I talk to them and saying, do you do any aligners? He goes, yeah. I was like, what about fixed appliances? And they go, oh, well, no, I didn't think I could do fixed appliances as a general dentist. I thought, well, doing aligners, what's the difference? Orthodontics is orthodontics. As far as the GDC is concerned, you are moving teeth. So you need a full assessment diagnosis. You need to be able to give the patient all the treatment options. Now, if you don't know what all the treatment options are, should you then be doing the treatment altogether? If all you're offering is Invisalign and the another treatment option is going to be extraction of upper fours to camouflage that class 2, but you're not offering that, and you're not offering fixed appliances. It could, even as simple of, I could do aligners here, or it could be a referral to a specialist, have this, and that's absolutely fine if you don't want to take on those cases yourself. But that has to be in the consent form as an alternative option. Does that make sense?
Makes perfect sense. And so one timely thing that this episode's come at a good time for us, because in the protrusive community, what we're doing is we're actually collecting everyone's consent form. So hundreds of dentists are sending their consent forms. We're picking one topic at a time, and we're creating essentially the ultimate consent forms. I go through it, Zaira goes through it, Chriselle, these are all dentists that go through it. We then plug it through AI. Then Alex, our manager, who's a non-dentist, will go through it, and then we'll also plug into AI again. What are the holes in this consent form kind of thing? And so what I've gathered from what you just said there, Zaid, is everything that we said so far is good, but if we had these 2 extra bits added in to our consent form that we're kind of building in our head and that we can release from this episode, is one is alternative options, and to just make it out there and then scriggle, okay, this could be done with a specialist, and that will keep you as a aid memoir to remind GDPs to offer fixed appliances if they're not doing it, or an onward referral. And the other one could be called considerations and compromises, right? And so, look, this is a consideration that, okay, we can do this, but you might end up having a big overjet, and explain that way. Or consideration of this approach is that we might be able to get 80% correction as rotation. It's probably unrealistic to expect perfect. If you're looking for a bit more, you probably need fixed appliances, and to, is that okay with you or is that not? And the best time to find out is now. So we had those kind of two sections. And Neil, any reflections on the ultimate consent form or just consenting in general?
I think the consent form, as we said, is part 1 of the 2-part conversation or the video. So that should be clear if anyone's using that. And I think also there should be some sort of timestamp on that consent form, because in a year, things will change. In 2 years, progress, technology, etc., will change. Risks may change. We might handle things a bit different. So this consent form isn't valid for 50 years, for example. So I would just put a little proviso, medico-legally. This is a guide. This is not the absolute, and this should be updated at a regular basis.
Okay, that's interesting. Well, you guys have covered everything I wanted to do in terms of consent. I think there's lots of takeaways there for us to have the correct type of discussions. I just want to take a moment to welcome you, to tell us more about what you do, how can we reach out. So firstly, Zaid, you teach dentists, you mentor dentists. How can we find out more about your programs? What is it that you teach? Is it fixed appliances or aligners?
Yeah, so I set it up earlier this year, where it's a fully online remote platform, and it's teaching orthodontics. So I think whether you do aligners, whether you do fixed appliances, we go through assessment and diagnosis, we go through treatment planning. So you are able to offer, you may not be able to come from doing it yourself, but you know what to look out for, what the alternative options are. So we cover fixed appliances, we cover aligners, we cover all aligner platforms. We're not tied in with one aligner company over another. But the key thing is with that is the mentoring aspect. So I think what sets it apart is not just the course. The course is fully online. You can watch the videos as and when you need to. You can go back and watch it as many times as you want. But it's the best way of learning is by doing. The online platform has a approach where you put photos up in a secure platform, and the conversation back and forward of, okay, this is a suitable case, and the plan is going to be fixed appliances and non-extraction. But then the dentist would then do it, take photos at the end of the appointment, put that on. So each case has a thread, and then say, right, great, yeah, I can give them feedback on the bracket position, give them feedback on their ligation. Right, next time put an 0 and 8 time there, and same again from start to finish. We go back to our dental school days. How did we learn? By doing a filling. How did we have that supervisor or clinic who checked every visit? Now, the orthodontic form, the actual fitting of the appliances, the actual adjustments, it's straightforward. We have orthodontic therapists who've done 1-year training, they've gone from a nurse to treating patients, and they've never been in the mouth before, while dentists are used to etching, bonding, sticking stuff to teeth. It's all in the planning, and it's all doing kind of efficient mechanics. So with the aligner aspect, we'd go through their ClinCheck, we'll assess it. And it's not like a ClinCheck service in a sense, because firstly, we're checking if the patient is appropriate for that. We would know from the start and go, okay, we know that lower 3 is not going to rotate. And if it is a fix, if they do need a sectional fix at the end, of course, it already covers it. So there's no reason why you can't put a sectional fix at the end if the patient isn't happy. It's not a failure in treatment. We know there are limitations with aligners. We know there are certain things that's very good at moving, and certain things it's not. But the key thing is picking up from the start. So if you consent the patient to say, right, either we do all the fixed appliances, or we do as much as we can with aligners, and anything that's fallen short, we can maybe able to mask with a bit of bonding, or we can put a fixed brace on for a few months at the end and let them decide. So, but if you're able to do that yourself, put the fixed sectional at the end, then it's much easier. There's not that worry of how much is orthodontist going to charge to do that, and it's that back and forward. So it covers that, it covers retention, and with the aligners as well, like the sort of ClinCheck surveys, if they think the case is suitable, we go through the ClinCheck together, but also when they come back in for refinements, we'll talk out to refinements. It's all kind of covered from start to finish. There's the online orthodontic academy.co.uk, and the whole process of it is, I'm the person that mentors everyone, so I get to know what level the dentists are at. But then I can like we personalize our consent to patients, I can personalize my teaching methods to each dentist. I'll get an idea of what level each dentist is at, and then be able to know what treatments they can and are capable of treating. I think with proper mentorship, there's no reason why most dentists can't do most cases, really.
I think mentorship in implants and orthodontics, especially, just the culture is there, and I think should be there in all other parts of dentistry as well. We're trying to change that to a platform called Intaglio. We welcome mentors to actively do some more mentorship, and I think orthodontics, really lends itself well to that.
So happy to offer 10% off for all our mentorship platforms and the course with the code Protrusive. You'll be able to log in and request the code straight away. And because it's fully online, it can be done from the beginning. There's no cohort intake, so you can sign up at any point. Like the mentorship starts from the beginning. Also, we offer, you can even do a diploma in orthodontics, so level 7 diploma in orthodontics, to give you that extra accreditation, and again, all done online and all done remotely.
Amazing. I'll put that in the show notes, and thank you for extending a discount to the community. I have no financial interest in it, but I always like to give my community a good deal. Neil, before we wrap away, my friend, please tell us about how you can get in touch, because you're so connected in space. The only reason I'm with PDI is because I trust you. We've had this conversation before. I'll be honest, I haven't had to use you guys much, thankfully. Okay, touch wood. Okay, but I know that when the time comes that there's a trustworthy person, organization, the culture behind the scenes, that gives everyone an incredible rate. Okay, it's not just me. I get the same rate everyone basically, but it's great to be able to have the paying way less than we do with the big three, if you like.
No, we had really good feedback on the support we're giving, and any issues or at all, people can text me or WhatsApp me, or small bits of communication. That's what we're there for. We're there to facilitate. So you can find us on professionaldentalandemnity.co.uk, and you can WhatsApp me 24/7. I'm usually away with the little ones. Email, obviously, anytime. But really, we want to have a personal relationship and an arm around you, and make sure we're looking after you, and it tends to be for life. Our retention rate's like 97% or 98%. So, we want to look after you for your career so that you can enjoy your career. And, you can look at who's joined us and how long they've stayed. So we must be doing something right. And I think there is a Protrusive discount as well. It'll come up in the pro forma when you renew.
Yeah, I'll put that in the show notes. Now that one, I'm very honest, that one I do have a financial interest in, but I'm going to put that in there just so everyone knows. But I myself use PDI, and hundreds of Protrusive already do, and it's served us well. So Neil, thanks again, but more than anything, helping us with the education side of things. Okay, so thanks so much. Zaid, thank you for covering that as a really comprehensive overview of consent. I'll send you our consent form, the ultimate one, once you made it, because line is what we're doing next, actually, to cast your eye and give us your opinion. That'd be great. We'll put you like a sealed and approved by Zaid, and of course Neil, you as well. I think it might be good to get your collaborative approach. And Neil, you'll probably put holes in it and say, okay, have you done this? Have you done that? Have you done this kind of thing? But that's what we want, right? We want to make the ultimate consent forms, but everyone to realize that it's not just a consent form. There's multiple layers to it, as we said, and that's what ultimately keeps us safe. So guys, thank you so much, and I look forward to recording again with you guys one day.
Thank you, Jazz. Thank you, Zai.
Thank you, Jazz. Appreciate it.
Thanks so much.
Thank you.
Well, there we have it, guys. Thank you so much for listening to this episode on consent in ortho all the way to the end. I hope you've gained some communication tips, or reconsidered how you consent for ortho, or some certain points which you now remember to emphasize a bit more. In particular, how to make consent individualized to your patient. In healthcare, there's no more space for generic templated consent forms. And whilst the forms themselves are not the problem, is how do you individualize that form to the patient who's in front of you? Now, if you'd like to learn more from Dr. Zaid, please check out below for the link. And if you're paying too much money for your indemnity and you're looking into an insurance-based product, check out protrusive.co.uk/insurance. That's protrusive.co.uk/insurance. Get a quote and get a Protrusive discount of £100. It's with PDI All Med Pro. That's why I have my insurance with, and have done so for many years, because I was sick of paying so much money to the mutuals for their discretionary care. If you don't know what any of this means, do check out an older episode. It was indemnity versus insurance. But if you already know and you just want to get a quote to see how much money you'd save, once again, it's protrusive.co.uk/insurance. And a reminder that this episode is eligible for CPD and CE credits. We are a PACE approved education provider. For those premium members, scroll down below, answer the quiz, get 80%, and our CPD Queen Marie will send you your certificate. If you're not on the app yet, what are you doing? Especially if you're a regular listener, you need to be on our membership so you can get CPD all year round. You'll get 50 to even 100 hours every year. Because whilst we have a new episode every week, we have so many live and replay webinars. We love doing the clinical walkthrough videos, so it's well worth it just for that. It all starts with a 7-day free trial. Check out protrusive.co.uk jazz.com/ultimate. And we also have our own AI. It's called Ask Jazz. You can literally ask it anything you want. And we use the entire database of Protrusive, all the guests we've ever had, all our courses to help give you a well-considered answer. It's kind of like chatting to all the podcasts at once. That's on the Protrusive Infinity plan. Check out protrusive.app to learn more about all these options. Thank you so much, Protrusive. I'll catch you same time, same place next week. Bye for now.